say that they have a black button in front of them. It can persist for a few minutes. If it's for a few minutes, we will say transient blurring or loss of vision. Basically, the pathophysiology of loss of vision, acute loss of vision, we can divide it into three. Number one are the media opacities. The optical media, you know that what are the optical media? Cornea, aqueous, lens and vitreous. These are the media which allow the light rays to cross them and fall onto the retina. If there is any opacification in them, we will say that the patient is having a media opacity. The second is the retinal abnormality. The most important perceiving part of our eyeball is the retina, which receives all the light rays and convert the light energy through the chemical energy into the electrical energy, and that goes to the brain via the visual pathway. Okay. The third is the visual pathway abnormalities. Okay. ये तीन चीजें हैं जिसकी वजह से the patient might have acute loss of vision. Now the loss of vision might be painful or painless. This is also an important question that we have to ask during the history taking. The history taking का एक हिस्सा है. So if he says that he has loss of vision and along with that he also have pain in the eye, then what might be the causes? There might be corneal ulcer, keratitis, uveitis, angle-closure glaucoma, or optic neuritis. These are the causes of painful loss of vision. ये आपके शॉर्ट नोट्स में आ चुका है, इसलिए आज हम इसको सेपरेट क्लास लेकर चल रहे हैं. एक दफ़ा आया था what are the causes of acute loss of vision. Then there are painless causes of loss of vision. That might be the vascular occlusion, either the central retinal artery occlusion or the central retinal vein occlusion. Then retinal detachment, age-related macular degeneration, and the vitreous hemorrhage. These are the painless causes of loss of vision. Let's first take the painful causes of loss of vision. If the patient have corneal ulcer, what are the risk factors? Trauma is the biggest risk factor in our community. That a trauma predisposes to corneal ulcer. Especially if it's a vegetative trauma, it will lead to corneal ulceration. If it's a metallic foreign body, even then it can cause the corneal ulceration. Similarly, contact lenses nowadays very much used among the young adults, and during the wearing and unwearing of contact lens, they might cause abrasion of the cornea, and then secondarily the bacteria might reach there and cause corneal ulcer. Poor lid apposition. Poor lid apposition means that if a patient is having facial palsy, what is going to happen? That is orbicularis oculi will not work. And you know that orbicularis oculi is a muscle which closes the eyelids. When the eyelids will not close properly, what's going to happen? That the lid is going to remain open. The lids will not close. And this non-closure of the eyelids is a predisposing factor that allows the foreign bodies and the other hazards, atmospheric hazards, to reach the eye, inside the eye. Then history of ocular surgery. If there is any surgery of the eye, and during surgery if there is any trauma to the cornea, or post-operatively the excessive steroid usage might cause the corneal ulceration. Last one is also the same, chronic topical steroid. Steroids are very magical medication, very much used in the eye diseases, but you know that steroids are anti-inflammatory, but they also reduce the immune system. And therefore, when the immune system is reduced, there are chances that infections can invade the organ or the tissue and they will cause the damage to the tissue. Symptoms? You know that what are the symptoms of corneal ulceration? There will be pain, watering, photophobia, okay? And there might be decreased vision if the ulcer is in the center of the cornea especially. Then there is discharge, redness. If you will examine the ulcer, you can get an idea about the cause of the ulcer. For example, if the ulcer shape is in the form of dendrite, you will come to know that it's the herpes simplex ulcer, dendritic. If the ulcer is grayish white and it is associated with hypopyon, then you will say that most probably it's a bacterial corneal ulcer. If the ulcer have feathery margins and it also has satellite lesion around it, similarly it also has hypopyon in grayish color, then you will say that most probably it's a fungal corneal ulcer. So with the morphology you can easily differentiate the type of the ulcer. तो morphology देख के आपने उसको diagnose करना है, ठीक है? This is an example. You can see that corneal ulceration is nearly central corneal ulcer. Okay. Along with that, this is hypopyon, and anterior chamber. You can see pus has been accumulated, and along with that there is a central corneal ulcer. So this picture also came once in the exam, in the statistician. You should remember that you have to mark it as corneal ulcer with hypopyon. Similarly, there are other causes of the corneal ulcer or keratitis, and they are the bacterial, viral, acanthamoeba, fungal, and interstitial. Common causes of bacterial corneal ulcers are the Staphylococcus, Pseudomonas, and the Haemophilus influenza. We will not go into very much detail, just superficially, because we have already done this topic of corneal ulcers. The clinical features as I just described to you. And what is the treatment? If the patient goes towards to a general practitioner, he should immediately refer to ophthalmologist. And what the ophthalmologist should do, that as soon as the patient comes to him, he don't have to start the antibiotics or any antivirals or antifungals. He should first of all take up the scrap and send it to the laboratory for staining and culture. From that he will come to know that which type of microorganism is the culprit, and he is going to target his treatment over that. Okay? Then give topical antibiotics. In severe cases, when the treatment fails, the final option is the corneal grafting, that you have to remove the part of that cornea and graft, implant and another graft over it. This is called therapeutic corneal grafting. Therapeutic corneal grafting. We have gone through the herpes simplex. That herpes simplex type 1 is the basically microorganism that causes the dendritic ulcer. Over here in this picture, again it have come multiple times in your exam. These are the small dendrites that you can see onto the cornea, and they are greenish because they have been stained with the fluorescent. Complication of any ulcer. This is not, just bounded to this type of ulcer. For any type of corneal ulcer, it can lead to corneal opacification and scarring, and that is permanent, and that will lead to the loss of vision. Okay. We know that whenever there is a herpes simplex infection in the eye, we should avoid steroids and we should give topical antivirals. On the other hand, if it is herpes zoster, we have to give not only topical antivirals, but we have to give oral antivirals also. Okay? In herpes zoster treatment and herpes simplex treatment, the difference is that you have to give oral antivirals in herpes zoster along with the topical. Okay? Steroids यहाँ पे भी जो है, mostly you have to avoid. Only in that case where there is iritis, that is anterior uveitis, over there you can use the steroids. Otherwise, try to avoid steroid in any herpes infection. Okay? Again, you don't have to go into the detail. There are shingles around the eyeball, and they are only fixed onto one side, that is either onto the right side or to the left side. Okay? They will not cross the margin, central margin. As you can see in this picture, that there are shingles around the eye. These skin lesions, which are basically which starts with macule, papule, vesicle, and then pustule, and then scar. This is the normal roadway to the skin lesion in herpes zoster. Macule, papule, vesicle, pustule, and then finally the scar. So that scar is also painful. Not only the vesicular reaction and all these are painful, but even the scar that is left behind is also very much painful. And I remember that I told you during the lectures that if you encounter a patient who is having herpes zoster, try to start antivirals within 72 hours of the onset of the symptoms. Otherwise, these antivirals will not work. The efficacy depends upon the onset of the medication. आपने देखा कि पेशेंट आया आपके पास और वो कह रहे हैं कि कल से स्टार्ट हुआ है, just start antivirals orally as soon as possible. But if he says that 1 week have passed, then you should keep in your mind that antivirals, okay, you can give, but they will not work nicely. तो एक हफ्ता हो गया, अब नहीं हो सकता, ठीक है? This is the picture. Multiple times it has come into your exam. We have a slide of picture of this for a static station. You can see that one side of the face is involved, that is the forehead, around the eye, periocular region, and the nose up to the tip. Do anybody know the sign that is? कोई एक यहाँ से मेरे को बताएगा? कोई एक बताएगा? हाथ ऊपर करके बताए. Which sign is it? हाँ, ये बता रही पीछे तो जी आप बताएं. अच्छे से, ठीक है? तो this is a sign which shows that herpes zoster has involved the tip of the nose, and why it is? What is the clinical importance for this sign? That whenever this sign is positive, it shows that intraocular tissues will also have been involved due to herpes zoster. Once you see Hutchinson sign positive, it is not possible that eyeball might have spared. तो जरूर उसमें अंदर infection हुआ होगा, ठीक है? Then into uveitis. We have discussed about the uveitis, anterior, intermediate, and the posterior uveitis. They might also cause decrease in vision. Okay? They might cause decrease in vision. They might cause a little bit pain, photophobia, and redness of the eye. Angle closure glaucoma, a very common cause of loss of vision or decrease in vision because of high intraocular pressure, it doesn't directly damages the optic nerve. Okay? This is the difference in between the open angle glaucoma and the closed angle glaucoma. That in open angle glaucoma, the decrease in vision is slow and gradual, and the cause is damage to the optic nerve and the visual pathway. वही होता है ना? But in closed angle glaucoma, there are acute attacks, among which or in between which the eye is normal. In that case, if a patient has acute angle closure glaucoma, the cause of decreased vision is not the optic nerve damage. The cause of decreased vision is corneal haziness, corneal edema. ठीक है? Cornea जो है, that is very transparent structure, and if fluid accumulates in it due to high intraocular pressure, it will not refract the light rays, and the patient will have decrease in vision or loss of vision. ये सारी चीजें आपको हम angle closure में बता चुके हैं that more than 40 millimeter of mercury if the pressure ensues, then what's going to happen? The endothelial pump will not work and the cornea will get edematous. When it will get edematous, the vision will reduce. But in chronic angle closure glaucoma, what happens that the optic nerve and the optic disc, it also compromises. फिर वो जो है cause होगी, वो optic nerve damage होगी, ठीक है? लेकिन acute में you are going to say to your examiner that the cause of decreased vision or loss of vision is corneal edema, ठीक है? This is the picture, but it's not a clear picture. We have very clear pictures for angle closure glaucoma to show you an exam, and that will be having corneal haziness, ciliary congestion, and dilated pupil. This is the triad which will be shown to you in the exam. यहाँ पे इस पिक्चर में चीजें क्लियर विजिबल नहीं है, तो you don't have to worry. ये पिक्चर हम लोग एग्जाम में कभी भी नहीं देखते. And we have gone through the treatment plan for angle closure glaucoma. ये हम कर चुके हैं. We have to give anti-glaucomatous medication, especially the IV medication or the oral medication that includes the mannitol, acetazolamide, or orally also you can give azadam, acetazolamide, and then you have to lower the intraocular pressure. If not, you have to go for laser PI, peripheral iridectomy, and even if that doesn't work, you can go for trabeculectomy. Optic neuritis, a common cause of painful loss of vision, but over here the pain is not constant. The pain occurs when the eyeball moves. The patient will say that whenever he moves his eyeball, there is pain in the eye. So this is typical, characteristic of optic neuritis pain, that the patient will have pain during eye movements. But when the eye are not moved, he will not have any pain. So optic neuritis is basically inflammation of the optic nerve, and most of the time it is associated with a demyelinating disorder, which is the multiple sclerosis. I hope you have some idea of multiple sclerosis, and it especially affects the young to middle-aged peoples. The visual acuity is reduced, there is pain on movement of the eye, then there is field loss, photophobia, disc edema, and abnormal color vision testing. Now see that disc edema, bilateral is papiloedema. ये हम discuss कर चुके हैं. This is, you can say, a type of revision class. If there is bilateral optic disc edema, it is papiloedema. Okay? But if it is unilateral optic disc edema, it's not a papiloedema. It is just a disc edema. So in optic neuritis, if it is due to papillitis, it will be shown as disc edema, unilateral disc edema. Okay? But if there is retrobulbar optic neuritis, there will be no disc edema. The disc will be normal. Okay? So, inflammation of the optic nerve, which is called optic neuritis, it might be either papillitis, that is involving the disc, or it might be retrobulbar optic neuritis, that is the part of the optic nerve behind the disc. When the part of the optic nerve behind the optic disc is involved, it will not be shown on the disc. The optic disc will be absolutely normal. But if the part of the optic nerve which is on the disc is involved, it will be shown as disc edema and will be said to be papillitis. Okay? What is the treatment plan for optic neuritis? Up till now, the most effective treatment plan is to give steroids that have to be given either orally or intravenous. Okay? And hydrocortisone is the drug of choice that is given IV, but you can also give prednisolone IV or orally. Okay? Betamethasone can also be used, but most of the time hydrocortisone is used for treatment of the optic neuritis. Yes, if the steroids are contraindicated in that patient, then you can give anti-cancer or the immunosuppressant drugs. Okay? Because they are also having anti-inflammatory effect. Okay? अच्छा, इस पिक्चर में क्या मिस्टेक है? ये पिक्चर है, इसमें क्या गड़बड़ है? कोई बताएगा?
सर वैसे क्लियर ब्लर होंगे।
ठीक है, margins are blurred, they are not very clearly evident. The disc is looks to be swollen. लेकिन ये जो इसके नीचे लिखा हुआ है क्या ये सही है? Bilateral. उसने एक पिक्चर दी है और उसको पेपिलर में लिख दिया. He should have given picture of both eyes, and then it justifies that the patient has papillary edema. लेकिन यहाँ तो नहीं होगा ना, एक आंख थी. Let's come to the painless loss of vision. ठीक है? So it might be due to retinal artery occlusion. Now remember that central retinal artery is the main artery that supplies the inside of the eyeball, and if it is compromised due to any thrombus or emboli, लेकिन आर्टरी के अंदर क्या हो सकता है मसला? यही हो सकता है कि ब्लॉकेज हो जाए, तभी वो जो है ब्लड सप्लाई को रोक देगी. तो वो आइदर थ्रोम्बस हो सकता है, and it can be emboli. A thrombus, you all know that it's a localized origin pathology. Okay? While what is emboli? Yes, when the thrombus dislodges from the actual place, it can float up to the eye and it can block the central retinal artery. ठीक है? तो embolus के लिए origin कहीं और से भी हो सकता है. That's why if a patient comes to you with central retinal artery occlusion, you have to work up on the heart also. Why on heart? Because dysrhythmias or abnormal heart rhythms, they can also produce emboli. ठीक है? तो वहाँ से एम्बोलाई निकल के वो आएगा कहाँ पे? आर्टरी के थ्रू इसमें भी आ सकता है, कहीं भी जा सकता है बॉडी में, लेकिन सेंट्रल रेटिनल आर्टरी में भी आ सकता है. तो जो है देयर आर एम्बोलाई which might be either cholesterol or calcific, and they might lead to painless sudden loss of vision. Okay. Over there, what you have to do, you have to reduce the intraocular pressure abruptly. अच्छा, अब IOP से इसका क्या ताल्लुक है? ये तो ग्लोकोमा तो नहीं है, यहाँ तो आर्टरी ब्लॉक हुई है.
प्रेशर बढ़ेगा और रीडिंग होगी. ब्लड सप्लाई
नहीं, ये
ब्लॉक
रीजन नहीं है. You were near to it, but then you deviated from the main cause.
सर बिल्कुल स्लिप ड्राइव करेंगे ताकि प्रेशर की जगह से निकल जाए।
चलिए मैं बता देता हूँ आपको जैसे जी एक चीज मैं पहले बता चुका हूँ, देयर इज अ परफ्यूजन प्रेशर ऑफ द आई, ठीक है, एंड विच इज बेसिकली when you subtract the mean arterial pressure of the eye from the intraocular pressure, you will get a perfusion pressure, ठीक है, mean arterial pressure of the eye and subtract IOP from it, intraocular pressure. तो उसमें क्या होता है कि जैसे जैसे इंट्राओक्यूलर प्रेशर बढ़ता जाता है तो मीन आर्टीरियल प्रेशर कम होता जाता है, जो परफ्यूजन प्रेशर है वो कम होता जाता है। इसी तरीके से इसको आप इन्वर्सली लें, whenever there is central retinal artery occlusion, the mean arterial pressure will be reduced, but the IOP is same. अब जब आप उसी IOP पे मीन आर्टीरियल प्रेशर कम कर देंगे तो परफ्यूजन प्रेशर कम हो जाएगा, ठीक है। द परफ्यूजन प्रेशर इज वेरी मच नेसेसरी फॉर अ गुड एंड फंक्शनल आई, लेकिन अगर आप IOP को भी कम कर दें किसी तरीके से तो इट विल बैलेंस द मीन आर्टीरियल प्रेशर। मीन आर्टीरियल प्रेशर कम हुआ है, आप इसके साथ साथ IOP को भी कम कर दें, तो whatever result will come will be a little bit better and the perfusion will be good. So for a good perfusion to the eye, if the arterial pressure is reduced, you should reduce the intraocular pressure. ठीक है, ये थोड़ा सा समझने में मुश्किल है, लेकिन इस चीज को ज़हन नशीन कर लें कि अगर आई का आर्टीरियल प्रेशर कम हो रहा है तो आपको किसी भी सूरत में उसका इंट्राओक्यूलर प्रेशर के आंख को ब्लड मिलता है। अगर वही इंट्राओक्यूलर प्रेशर उसका अपना जो ओरिजिनल है उतना ही है, मींस 20, और उसके परफ्यूज और उसका आर्टीरियल प्रेशर कम हो गया है तो इट विल नॉट बी परफ्यूज। सो फॉर अ गुड परफ्यूजन यू हैव टू लोअर द इंट्राओक्यूलर प्रेशर। एक मसला हो चुका है, उसमें आर्टीरियल ऑक्लूजन हो चुकी है, अब ब्लड नहीं मिल रहा, तो उसी जो थोड़ा बहुत मिल रहा है एटलीस्ट वो तो पहुंचे, तो फॉर दैट यू हैव टू रिड्यूस द इंट्राओक्यूलर प्रेशर, और व्हेन यू विल रिड्यूस द इंट्राओक्यूलर प्रेशर a little bit perfusion will reach all parts of the retina and it will start functioning. तो उसके लिए जो है आप क्या करते हैं, आप उसको जो है उसकी आंख को मसाज करने को कहते हैं, because it will lower the intraocular pressure, or you will give anti-glaucomatous or IOP lowering medication, तो ये सारी चीज़ें देते हैं। और अगर बहुत ही तेज़ी से IOP कम करना है तो आप क्या करते हैं, पैरासेंटेसिस करते हैं, पैरासेंटेसिस करते हैं। ये पता है आपको, इसकी मैं एग्जांपल देता हूँ। फॉर एग्जांपल इफ पर्सन इज हैविंग एसाइटिस इन द एब्डोमेन, व्हाट यू डू, ड्रेन करते हैं ना, उसमें फौरन ट्यूब डाल के आप उसकी जान बचाने की कोशिश करें। इसी तरह से चेस्ट में होता है, चेस्ट ट्यूब डाल देते हैं तो फौरन जो है वो उसको जो है लंग्स जो है एक्सपेंड हो जाए, ठीक है ना। इसी तरीके से आई में भी ये है, आप फौरन एक सुई चुभो दे कॉर्निया के अंदर, so what's going to happen, that aqueous will come out, ठीक है। when the aqueous will come out very fastly, it's going to reduce the intraocular pressure very very rapidly, और उसी वक्त आई सॉफ्ट हो जाएगी और परफ्यूजन स्टार्ट हो जाएगी। and don't worry about that pinch that you have done, because it's going to heal after some time, और फिर वो फिर से वो वापस प्रेशर हो जाएगा, लेकिन उस वक्त के लिए आपने उसकी जान बचा ली, ठीक है ना। जिस तरह आप थोरैक्स में और एब्डोमेन में वो ट्यूब घुसा देते हैं, उस वक्त आप ये नहीं सोचते कि ये तो मैंने सुराख कर दिया, बट दैट विल हील लेटर ऑन। इसी तरह से आई में भी वो हील हो जाता है, ठीक है। सो पैरासेंटेसिस जी, reduce is as much as you can, because mean arterial pressure, you don't know about what is the actual mean arterial pressure at the moment, वो आप नहीं काउंट कर सकते। तो जितना हो सके आप आंख को हाइपोटमी में डाल दें। हाइपोटनी मींस बिल्कुल प्रेशर लो कर दो, जितना प्रेशर लो होगा उतना ब्लड जो है वो अंदर जा सकेगा। सो यू हैव टू रिड्यूस इट, देयर इज नो फिक्स्ड हार्ड एंड फास्ट लिमिट दैट हाउ मच इट बी डन। अच्छा, एक और तरीका होता है कि पेशेंट को कहा जाता है कि ब्रीथ विथ अ बलून, एक बलून उसको दे दिया जाता है और उसको कहा जाता है कि ब्रीथ इनटू दिस बलून, मींस इंस्पायर एंड एक्सपायर, इंस्पायर एंड एक्सपायर। तो वो आप उसी बलून के अंदर, सो व्हाट्स गोइंग टू हैपन विद दैट? भाई एक आम फिजा में आप जब सांस ले रहे हैं तो यू आर टेकिंग ऑक्सीजन इनसाइड एंड यू आर रिमूविंग योर कार्बन डाइऑक्साइड, एक्सहेलिंग कार्बन डाइऑक्साइड। और जैसे ही आप कार्बन डाइऑक्साइड निकालते हैं मुंह से तो इट विल डिफ्यूज इनटू द एटमॉस्फेयर और एक फ्रेश ऑक्सीजन आपके अंदर चली जाती है। लेकिन जब आप एक बलून के अंदर रीब्रीथ करेंगे तो द कार्बन डाइऑक्साइड विल accumulate over there. The concentration of carbon dioxide is going to increase in that balloon. वो बाहर तो नहीं जा रही। So this time when you will inspire, it will be having more carbon dioxide as compared to oxygen. तो उसमें ऑक्सीजन इतनी नहीं होगी, उसमें कार्बन डाइऑक्साइड बढ़ती जाएगी। So when the carbon dioxide is inhaled, the level of carbon dioxide will increase in the blood. When it will increase in the blood, what's going to happen? It will dilate the blood vessels of the whole body. When the whole body blood vessels will dilate, the perfusion to eye will increase. तो ये भी एक तरीका है जिससे जो है उसी वक्त जो है ये तरीका कार किया जाता है ताकि जल्दी से जो है उसकी परफ्यूजन कुछ बेहतर हो जाए। ठीक है। Then there is retinal detachment. You know about it, separation of the sensory retina from the retinal pigment epithelium. There are 10 layers of retina. I hope you remember them. The examiner asked about them. So remember the names of the 10 retinal layers. The outermost is the retinal pigment epithelium, which is in contact with the choroid through the Bruch membrane. तो ये आपको याद होना चाहिए। अब वो रेटिनल पिगमेंट एपिथेलियम अगर बकाया सेंसरी रेटिना से डिटैच हो जाती है तो उसको हम कहते हैं रेटिनल डिटैचमेंट। कई बार स्टूडेंट्स गलती से कहते हैं द डिटैचमेंट ऑफ रेटिना फ्रॉम द कोरोइड इज द रेटिनल डिटैचमेंट। नो, द डिटैचमेंट ऑफ द पिगमेंट एपिथेलियम फ्रॉम द सेंसरी रेटिना इज द retinal detachment, in which the patient in the beginning will have flashes and floaters. ठीक है, आदि आपको पढ़ाया गया होगा यकीनन, तो प्रारंभ में पढ़ाया होगा। तो the patient will have flashes and floaters which are sign of traction onto the retina, and then finally there will be curtain in front of the eye, and the part of the retina which is detached, it will be shown into the visual field of that patient. If superotemporal retina detaches, the infero-nasal field will be lost. Similarly, if the inferotemporal retina is detached, the superonasal field will be lost. ठीक है, ये opposite है, ये आपको पहले उन्होंने यकीनन बताया होगा। So if there is retinal detachment, there is painless loss of vision. जी, metamorphosia. This is basically a sign of damage to the macula. ठीक है, जब तक retinal detachment periphery में होती है तो central vision उसकी अच्छी रहती है, but whenever the retinal detachment ensues up to the macula, it will spread the fluid which is in between the sensory and the retinal pigment epithelium. It will spread onto the macula, and then what will the patient see? The patient will see distorted image. भाई देखिए central vision उसकी macula से control हो रही है, अगर macula में भी detachment शुरू हो जाएगी तो क्या होगा? अब उसको चीजें टेढ़ी मेढ़ी नजर आना शुरू हो जाएंगी, and they will not be of the actual shape. So this is termed metamorphosis. ठीक है, ये एग्जामिनर पूछते हैं व्हाट इज द डेफिनेशन ऑफ मेटामॉर्फोसिस। इस शेप इसमें और रेयर में वो दिखा रहे हैं कि भाई आप देखें कुछ पोर्शन ब्लैकआउट हो गया है, ठीक है, और कुछ पोर्शन जो है वो टेढ़ा मेढ़ा सा हो गया है और चीजें अपने शेप में नहीं होती ज्यादा, ठीक है। दिस इज अ पिक्चर ऑफ रेटिनल डिटैचमेंट। For retinal detachment, the only technique is surgery. Vitreous hemorrhage, blood into the vitreous. This is also a common cause of loss of vision, which is painless. इसमें भी दर्द नहीं होता, सिर्फ विजन चली जाती है। आप जब प्रैक्टिकल लाइफ में आएंगे तो you will encounter, you will see patients who will come to you with loss of vision and they are diabetic. बहुत ज़्यादा लोग होते हैं diabetic. So especially the diabetic patient, they have diabetic retinopathy and the neovessels they bleed again and again. तो हर दूसरे तीसरे महीने में जो है उनको vitreous hemorrhage होता रहता है, ठीक है। तो whenever the retinal blood vessels they bleed, they have only two sides to go. One is to stay there and cause dot and blot hemorrhage. The other is to stay in the space in between retina and vitreous. एक छोटी सी स्पेस होती है, डेड स्पेस इन बिटवीन रेटिना एंड विट्रस, तो वहां पे जमा हो जाता है, तो उसको हम कहते हैं प्री रेटिनल हेमरेज या रेट्रो हाइलोइड हेमरेज। लेकिन अगर वो इसको भी क्रॉस कर जाए और विट्रस के अंदर घुस जाए वो ब्लड, देन इट विल प्रोड्यूस विट्रस हेमरेज। सो देयर आर 3 sites where this blood can go. ये जो blood vessels हैं ये 3 जगहों पे जा सकते हैं। तो retinal hemorrhage, retrohyaloid और pre-retinal hemorrhage and the vitreous hemorrhage. Day before yesterday we have seen a patient who was having abrupt loss of vision due to vitreous hemorrhage. He was not diabetic, no any other comorbidity, and he was saying that he abruptly had this after vomiting. Basically हुआ क्या था कि there is a Valsalva retinopathy, ठीक है। During vomiting क्या होता है कि इतनी जोर से पेशेंट वोमिट अगर करेगा तो उसके जो है वेगल रिफ्लेक्स भी उसमें होता है। तो what is going to happen that small minute blood vessels, especially in the macular area, they will bleed. And that blood again can accumulate in the retina, in the pre-retinal space, or sometime it can go into the vitreous. तो इसमें vitreous में चला गया था। तो vitreous hemorrhage due to Valsalva manure can also occur, ठीक है। तो डायबिटीज में स्पेशली vitreous hemorrhage होता है, and the patient will have loss of vision. And how will you come to know that the patient is having vitreous hemorrhage? You have to examine and see the with fundoscopy. You have to see you have to see with the ophthalmoscope. And what are you going to see? There will be no red reflex, ठीक है। तो vitreous hemorrhage में आपको जो red reflex नजर आता है वो नजर नहीं आएगा रेटिना का, जो रेटिना के पीछे प्रोवाइड कर रहा है। And what is the treatment? You have to remove this vitreous hemorrhage. ये है पिक्चर, ये एग्जाम्स में कई दफा आ चुकी है, that you can see that there is blood almost in all the parts of the vitreous, ये पूरा। और कैसे आप कह रहे हैं कि ये रेटिना में नहीं और विट्रस में? Because you can't see the background retina. इसके पीछे वाला रेटिना यहाँ पे आपको नजर नहीं आ रहा, यहाँ नहीं आ रहा, ठीक है। जी, जबकि इस कोने में आप देखें रेटिना नजर आ रहा है, यहाँ पे भी आ रहा है। This is a picture of vitreous hemorrhage. Remember this picture. AMD ये आपके सिलेबस में नहीं है, इसलिए हम लोग नहीं पढ़ाएंगे, but it is also one of important cause of loss of vision, और उसमें कुछ इस किस्म का पेशेंट को नजर आता है। The name suggests age-related macular degeneration, means the macula degenerates, and macula you know is responsible for central vision. तो वो पेशेंट जहाँ भी देखेगा उसको बीच में एक काला धब्बा नजर आएगा, there will be a central sputum, नजर आ रहा है? पेरिफेरी में उसको नजर आएगा क्लियर, लेकिन जो सेंटर है वो गायब हो जाएगा। So this shows macular, pathology, and in this case, this is AMD, age-related macular degeneration. ठीक है? जी, so this completes the topic of acute loss of vision. आपने असल में शॉर्ट नोट होता है तो उसमें इतनी डिटेल नहीं लिखनी। आपको आज जो हमने पढ़ा है इसकी सिर्फ हेडिंग्स डाल देंगे, then still it will be enough। तो ये एक लिस्ट आ जाएगी कि भाई क्या क्या कॉजेज हैं लॉस ऑफ विजन। इफ यू आर राइटिंग विट्रस हेमरेज, डोंट गो इनटू द डिटेल्स ऑफ विट्रस हेमरेज। इफ यू आर राइटिंग कॉर्नियल अल्सर, डोंट गो इनटू द डिटेल्स ऑफ कॉर्नियल अल्सर, बट एटलीस्ट एनलिस्ट ऑल दीज थिंग्स। क्योंकि अगर आपने ये सारा लिखा तो एक ही सवाल में आपका टाइम पूरा हो जाएगा। ठीक है? शॉर्ट नोट का मकसद होता है ज्यादा से ज्यादा 1.5 पेज 1 पेज, इससे ज्यादा नहीं होगा। तो ये थोड़ा ख्याल